Are we all back and ready?
Yes.
Great. So I can say good afternoon to everybody now, and it's good afternoon if you are in the US for everybody. Thank you for coming back. I am really inspired hearing from everybody earlier in terms of the roles that each of the different professions play in oral health. And now we're going to shift to the second part of our program where we'll be thinking about how a holistic health promotion approach for underserved populations and communities. And we'll start by hearing from people in the community about their experiences of who is taking care of their mind, mouth, and body, and who is offering or could offer prevention and holistic oral health promotion messages. And then we will spend a session discussing how we might operationalize an adapted model from the WHO that puts the whole person, mind, mouth, body, and spirit in the center, surrounded by a multi-generational family, community members, and advocates for health prevention and health promotion. So to get us started, I am very happy and honored to introduce our moderator, Dr. Anita Glicken. Anita is a social worker by training and is the executive director of the National Interprofessional Initiative on Oral Health, which is where I first met her about I guess maybe 10 years ago now. She's also a professor and associate dean emerita at the University of Colorado Anschutz Medical Center and has over 30 years of administrative research and education experience. For more details, I will refer you to her full bio in the agenda packet. And without any further ado, I will turn it over to you, Anita.
Thank you, Mayumi. I appreciate the introduction. So as you pointed out, in this session, we're going to be hearing stories from several individuals who tell us about the holistic oral health of people they know, people from underserved populations and communities. In the second half of our session, we've invited a panel of community health workers and educators to tell us about their experiences and give us a glimpse into the realities of the people and the communities that they work with. But first, I'm pleased to open this session with a conversation with Dr. Trina Brown, who will describe her journey as her sister's primary caretaker. I've had the pleasure over the past few weeks to get to know Dr. Brown, who is an author, a doctor of philosophy and humanities, and founder and CEO of 2 organizations that focus on caring for and empowering the whole person with dementia. Dr. Brown describes her passion for advocating for people with dementia, and her story is deeply personal. Today, we hope to learn more about Dr. Brown's story and how her experiences can help others better understand the importance of caring for the entire person, especially for those who lose the ability to care for themselves. I want to welcome Dr. Brown and tell you that it's a pleasure to be speaking with you today. I'd like to start with a description of your background, if that's okay. Can you please tell us a little bit about where you grew up and maybe a bit about your family?
Good afternoon. Thank you for having me as well. And thank you, Anita. It has been a pleasure speaking with you. I am originally from rural West Virginia. I'm a coal miner's granddaughter. I am the youngest of 10. And so coming from that area, I have been experiencing some things in regards of health issues, knowing about how to deal with family and loved ones. And so being from West Virginia, I moved to the Pacific Northwest in 1989. And so that's where I started my journey of knowing more about the career that I took into today. And so, and that leads me to talk a little bit about my story in regards of my sister and how she was my oldest sibling, the oldest sister, I should say, of the 10 children. And so she moved to Seattle, Washington in the 80s. And after I finished school at Marshall, I ended up moving to Seattle in 89 to be with my sister. So that's a little bit about that part of knowing a little bit about my background. and where I come from and how I got to this place of where we're getting ready to go into a deep subject.
Could you tell us a little bit about the importance of the mind-body connection to you, and how you got involved deeply in your sister's care?
Well, as I stated before, I was living in Seattle. My sister has started developing early onset. We did not know what it was. She was in her 40s. She had retired from a company of Big Brothers and Big Sisters of King County, had worked for them for over 19 years, moved back to the East Coast to be close to family and loved ones. After being close to family and loved ones, we started noticing some change. And as you know, going through the process of talking with me, she was going through that age where it seemed like going through the menopause and the female hormones were changing. And so she was stressed a little. And so she went through the process of talking to her doctor, her physician, and he said, well, I'm going to put you on an antidepressant, making sure that you're okay. And so from the age of 48, she went through that process. And by the time she was 51, we had a full diagnosis of early onset of dementia. So that was the changing ball for me, knowing about history of healthcare, knowing a little bit more about dementia, and knowing how to take care of my loved one. At that time, I made a decision to move back to the East Coast to be close, because I wanted to make sure that I took care of her and be there with my family at those times, because we did not know what it was going to end up to be. She ended up surviving almost close to 18 years with the early onset of dementia.
I'm sure over that period of time, you saw many changes in your sister, many changes in her capacities and abilities to care for herself. Can you tell us a little bit about who took care of your sister's whole health while she was ill, and what part you played in that, what part others might have played?
In the beginning, it was her husband and my niece. Towards the middle part of her life, I ended up taking full legal guardian over my sister because I know she needed more at that time. Then I needed to get more involved of knowing exactly what was going on from the medical side of it, as well as from just the holistic side of her whole being. And so I ended up getting legal guardian and being her care provider. Towards the last 3 years of her life, I did have her in a nursing facility just to make sure that she got 24-hour care. And so that was me being the caregiver for my sister. And up on doing that, I was able to know exactly what was needed from the dental side, from the medical side, and from her body. So basically what was going in her mouth, what was part of her, mental state, as well as her body, her mind in regards to the food that she was intaking. And so at that time of being her caregiver, I took on the role as being the advocate. So close to the last 18 months of my sister's life, she could not speak. So she ended up losing her voice. And so you're probably wondering, well, why is Dr. Trina here? Why is she at speaking to this conference and speaking to you all today? The last 18 months was a part of where it was a challenge because she could not speak. And so with her not being able to speak, I had to learn how to communicate through her eyes. I had to learn how to understand what was going on, the level of pain, the level of understanding how to care for her, even the oral part of her mouth, her health part. And so it got to the point where we had to know more about that piece. And so I think that is a big part of understanding the whole body. Knowing what's going in the mouth, because she wasn't able to speak. So that led to a part where she had to get certain foods pureed for her, making sure that it was cooked a certain way so she can digest it and put it into her mouth so she would be able to get the nutrition that she needed to survive the disease.
And I'm curious, during that time, what did you see the healthcare providers, the formal healthcare providers, potentially not yourself, or maybe including yourself, in terms of caring for her oral cavity. I mean, she needed that oral cavity to be able to take in the foods and to have some degree of health in her body. How did you see that working when she was in the healthcare system?
Anita, to be honest with you, the last 18 months, the first part of it was really okay. I was able to, she was a little still mobile. So I was able to take her to the dentist. It was a fight because when you put a person in the nursing facility, the doctors, the dental office have to come on site. And so I had to sign papers and state that I would take ownership to have her transported to a doctor that I can make sure that she got the proper care that she needed, because there is, as you know, red tape in regards of having a person in a facility and having the right dental physician to come into a facility to take care of that patient at that time. And if they don't feel that they can, then the patient suffer. And so I had to make sure that she had an abscess tooth near the end, but in the beginning, I had to make sure she got her cleanings, her the regular health care, I should say, for making sure she got all of the things that she needed at that time. So extraction, she had an extraction taken care of within that time frame. But when the more she got to the end of it, I seen that there was a neglect from the communication level of the medical side as well as the dental side in regards of making sure that the patient gets what it needs and how to make sure that the proper nutrition is implemented as well. Because the one thing about it that I learned is that after they start to not able to communicate, they have a hard time to drink regular liquids. So they have to give them a certain type of liquids to make sure they're getting the hydration that they need. And so that's another part of the medical side that I seen that was different, as well as the dental side. And so it took me literally almost 8 months, I believe a little over 8 months, to get a doctor on site to look at my sister to see that she had an abscess tooth. And so my sister at the latter part of her life did not pass away from dementia. She passed away from an abscess. And so because the doctor, the dentist office at that time, as you would know, dealing with patients that have long-term disease, they cannot open their mouth. They're not going to do exactly the commands that you ask them unless you have patience, unless you'll be able to work with them on an ongoing basis. And so it was to the point where, because she did not do the commands that they thought she should do, or either work with a special person that could give those type of instructions for her to be able to obey those, then it became a problem for her to open her mouth, but they can fully give her an exam. And so I found out after doing this and looking at my sister's situation, over 90% of the patients that's in a nursing facility does not get the proper dental care, sometimes because of the commands that's given to them in regards of making sure that they're actually able to cleanse their mouth. They can't use a regular toothbrush, so you use a swab to cleanse their mouth. You use different things. And so I think that was a part of the issue that we ran into, is that the facility did not have the proper dental or either physician, I should say dental physician at that time, to give the right necessary referrals to do an oral surgeon procedure. And so when they did come back and tell us that they were able to do it, it got to a point where it was a call that a family we had to make as a family, because it was a 50% that she would make it or 50% she wouldn't after having surgery done to her mouth to remove the abscess. And so we had to make a crucial decision of whether or not we were going to move forward with that.
Oh, thank you. Thank you for sharing that story. I think there's so many lessons to be learned from that. And particularly as you talk about that mind, mouth, body connection, and the decisions and the burden placed on the family in a situation where a patient isn't getting the care they need. And the family is having to make decisions that are much harder at that point in time. So I really appreciate and respect the care that you provided your sister. And thank you so much for sharing that, because I think it's very helpful and gives us a picture of what that might look like in this situation, and probably many others. Thank you.
And I believe so. I believe, and as well, Anita, that I know we had talked about this, and I am looking at my question here, and I believe that going forward, that we really have to, I was listening to the early sessions, and we really have to come to a balance of understanding the mental side as well as the dental side, and understand the whole person from that perspective of, my sister was in her 40s. It wasn't that she was 70 or 80 or 90 years old, because when you hear the word early onset of dementia, or frontotemporal is what she had. When you hear those type of disease, you're thinking of someone that is more seasoned, I call them seasoned, and are more graceful in the age. But when you look at it, having someone that was just as bubbly as me and you, being able to speak just as eloquent as me and you, go from that to not being able to speak at all, and having abscess tooth to cause the problem based off of not having a proper physician to look at her mouth, because he didn't have the ability to have her to open it properly, or even going and doing an exam to know. But you can actually, when I open her mouth, when I would tell her, Lynetta, open your mouth, we could see that there were things going on, but because my timing and his timing didn't work, he did not come in the hours that I was there. And so it was definitely something that I believe that going forward, we have to make sure that we work as a unit, or as a community, to educate not only the families, but the physicians that's involved, because we're not looking at just, as it says, the mouth, but we're also looking at the mind, the body, as well as the spirit. And so I think once we understand that it's holistically all parts of it, then it makes a difference on how we move forward in the future.
Yes, very well said. And I think that, one of the things you've pointed out is the patient should be at the center, and the family is in that circle as well, and as part of the healthcare team. And
Right.
not to overlook the importance of that family and the care of that patient. So thank you for that comment. I think it really speaks volumes about the experience of the patient and the family, and the lack of attention that we get now. So thank you very much. I appreciate your participation, and please stay around.
I will, thank you.
I'd like to now shift to our community health workers and educators to hear about their experiences working in and with underserved communities. In the interest of time, I'm going to refer you to their full bios in the agenda packet. And we'll start with Ashley Ford. Ashley is the Healthy Kids Project Coordinator with CARE South Carolina in Hartsville, South Carolina. And Ashley, I'd like to turn the mic over to you as you lead us off by sharing a bit about the oral health needs of your community, and perhaps maybe an example from your own work.
Thank you. Thank you so much. I would like to tell a little bit about, I've worked in dental health for 2 years. I was a community health worker for our dental department with CARE South Carolina. And I had many cases where I had to go into the home if it was an issue with communication between parent, guardian, and results of a child. With CARE South Carolina, we do focus on school-based kids. So I was in one school, and there was a student that kept going to the nurse, cover tooth pain. Our dental team, has seen the patient, have numerous attempts trying to reach the parent or guardian in regards to this patient. This patient was visiting a school nurse daily, getting Tylenol for toothache. So it got to the point where it was just really getting to a point, it was every day, and they were trying to attempt to contact the patient's parent. Well, the social worker with the school had to get involved. So she was like, okay, we have reached this parent, we try to leave voicemail, we have sent letters home, no response. And this child continued crying about a toothache your dental team has tried to reach her as well. So the dentist reached out to me initially to try to reach the parent, which I did, which was unsuccessful at first. But then I kept trying to reach the parent, and then come to find out, if I didn't step in when I did, the social workers was going to refer her over to Department of Social Services. So eventually I went to the home and I spoke with the parent. I was like, educating her. And I was like, listen, your daughter is, really has a tooth that needs to be filled. And, we have tried to reach you. Is it something? She's like, yes, I know. I'm a single mom. I'm working and it's hard for me to try to get her to the dentist. And I began to explain to the mom, I was like, listen, I understand, being a parent, sometimes it is hard, being a single parent, it's hard. But I asked her, I was like, did you know that she was going to the nurse? She said, yeah, I'm aware of that. But I thought, I've been giving her Tylenol as well. I thought that would take care of the pain. And it began to educate the mother. I said, no. I said, that's kind of like not doing to nothing. I said, that's almost like you've been in labor and, they give you a little bit of pain medicine, but it really don't stop the pain. The pain is going to reoccur. So she was like, okay, I understand. She said, but then as I sat down and talked with her, I understood, as she was saying, as a child herself, she had an incident with the dentist where she was scared. So she was kind of scared for her daughter to go to the dentist. So I educated her. I was like, listen, it's not going to be as bad as you think. I explained to her, if you would like to come in, because our dentists go to the schools and we see the kids in the schools, take them from the classroom for a short period of time, and we will see them. So I was like, if you would like to come to the classroom, you'll be able to sit there with her. She was like, no, I'm afraid of dentists. So that's why it kind of gave an overall picture. This mom said she's working, but she had other things like mentally where she was fearful for herself, and she kind of let it spill over to her child. So once I educated her, I said, listen, it's not going to be as bad as you think it's going to be. Our dental team is well aware of all, anything you can think of. You can ask them any question, or you can ask me. Then she kind of have a piece of ease upon her, come upon her about dental health. I told her, let's think about it. Our mouths are important. We eat, we drink. And I said, if she can't eat, I said, it's not only about eating or drinking, but it affects other parts of the body. And as I began to explain to that mom, she began to understand, okay, it's bigger than just a cavity. It's a whole lot of other things that could be affected. So successfully, we were able to get the child in to fill that cavity. But I just want to say it's all about how to communicate and get an understanding, because sometimes parents, sometimes they have a busy schedule, and sometimes it could be something within them that they're fearful that could kind of spill over to their child. So they're thinking, I'm scared to go to this, I'm not gonna let my child go. Or it could be other different barriers. So with my experience, meeting the parent or guardian where they are and understanding what's the issue and try to eliminate any barriers that I can help eliminate before it gets to a point where it will, go further than just a filling. It could be a root canal, something, more advanced. So that was my experience as a community health worker working with the dental department.
Thank you, Ashley. I think that's a great illustration of one of the important roles that community health workers play in meeting patients and parents, community members in their home, and providing just a little bit of information that can help potentially change the mindset of that parent, which then may help that child feel less nervous about going in to see a dentist. And kind of getting some comfort from mom for the information that you've provided as well. So do you have any other quick thoughts about mind, mouth, body connection? I don't have a lot of time, but I just wanted to see if there was anything else that you wanted to add to that.
Sure. When we think, I always tell patients this, if the mind is not together, it affects other parts of the body. So we wanted, it's easy for us to sometimes tell patients, well, you need to have this done, but we got to also understand, do they understand what we're saying? And do they understand the whole part of the effect if they don't get this done, if they don't get this tooth pulled, or if they don't get a filling, what it can affect down the road. Do they understand the foods that can cause cavities? So it's more than just oral health, but we have to look at the whole body as a whole, and how can they understand mentally that, okay, when you have pain, it's a reason why you're having pain in that tooth. You need to go to a dentist, and sometimes putting their minds at ease.
Thank you so much for sharing that story. Next, we're going to hear from Angel Martinez Thornton. Angel works as the community health manager for the Black Hawk Health Center in the Sac and Fox Nation tribe in Stroud, Oklahoma. Angel, you shared with me earlier that you live in Indian country in Oklahoma. So tell us a little bit about oral health needs and care in your community. And again, maybe by way of an example from your experience, because I think stories are so powerful.
Yes, I do. I think they're very touching as well. For us in Indian country, we have very limited on where our patients can be seen. So for an example, I'm the community health nurse. So we go out to our patient's home and assess them and see that they do need dental services. Therefore, referrals put in place to PRC, which is a purchase care referral unit. Each tribe is limited to a certain amount of funds. And in our tribe, we get $1,500 for a year of dental care. And you know, in the dental world, that money doesn't go very far because it's not insurance, it's a set amount. And once it's gone, it's gone. So therefore, we have to navigate and assist the patient through the whole, the dental process, understanding the treatment, what needs to be done right now, and what could potentially wait for next year. Because our patients here in Native country, they can't just go to any facility. It has to be a Native facility. And if they are referred out to a non-Native facility, they have to have a referral. They have to have paperwork. It's a complex process. So we help as a community health nurse, we help navigate that process and make it a little bit smoother for them to indeed get that care that will help them, that dental care, and make it a smooth process. In Indian country here, there are services that a lot of natives are not allowed to go to and it be covered. They can't just walk into the ER. They can't just walk into a clinic and be seen. They have to go to a Native facility, and there's not a lot of them here in Oklahoma. And we are rural, so you have a limited amount of selections of where you can go. And that's just one barrier. And another one is transportation. Here at the Sac and Fox Nation, we have an awesome community health program to where that we're able to assist patients. If they need to go to the dentist, we can take them to the dentist. We can help them with that referral process. So it helps cuts back on some of those barriers that we do find.
So if you find let's say a child in school starts complaining about dental pain, or my mouth hurts, okay, and every day they're going to the nurse or whoever's available to say my mouth hurts, what's their path to getting care? I mean, how does that, can you tell us how that flows?
A lot in Oklahoma here, we have school nurses, and they help reach out if that child is a Native child to that tribe. And a lot of the times we are brought in for community health because we help out in the community to help navigate that. If the child needs a referral, if they have insurance, where can they go? What does it look like? What barriers are keeping the patient, the child, from getting care? In Sac and Fox, we have a lot of elders that are raising grandchildren. So sometimes it's a really hard process of getting them into the dentist. We can help make that a smoother process for them.
And do they run into any, I mean, if a child is complaining of pain and you've worked with the grandparents and the other, or anyone else that might be a caretaker of that child, is it difficult to get the child in for care if they don't have insurance?
If they are a tribal member, no. No, and they haven't used their $1,500 that they're allotted to. It's not difficult because we have such a good working relationship with the dentists that are local of, hey, we have an issue. What can we do to get this patient in? How can we help them? It takes a lot of my staff to really navigate for that patient to help assist them through that process, because sometimes it's complex and it can be disheartening, especially if you're an older parent, grandparent, and you're raising that child, which is what we see in our tribe. They need that help and assistance of getting it done.
Mhm. That's really help. I mean, I think that's important information because we know that it's not easy to get in for care, even if you have the coverage to be able to do so. And I'm sure it takes a lot of energy from people like yourself and school nurse and other community health representatives, for example, to really make that happen. So I appreciate that story as well.
Thank you.
Thank you. Thank you for sharing it. And now I think we'll move on to hear from Kaushik Ahmed. Kaushik is currently an MPH student at Syracuse University, having worked for several years on community-based experiential learning for international students on social determinants of health in Bangladesh. My question for you, Kaushik, is a little bit different. Can you describe for us rural communities in Bangladesh and how community health workers interact with families in those communities?
Thank you, Anita, for your great introduction. I think, I mean, I would, at the very beginning, I'd like to start with the workshop theme that we have, mouth, mind, and body. So from my experience working, especially experiential working experience with the community, what I see is more about the body part, not the mouth or the mind part that we are really having here. So just to elaborate on that quickly, I would like to talk about how the healthcare structure is designed in Bangladesh. And I think that will kind of give us a clue where the oral healthcare lies and how this is conceptualized and the service around the healthcare is provided. So like other LMIC countries, Bangladesh health structure, basically healthcare is very, very pluralistic and organized by 3 levels. Like at the bottom, we have specialized or tertiary hospitals. And then at the district level, we have district hospital. And then we have at the community level, like community clinics. But again, the other feature is the healthcare is highly pluralistic. So no one stakeholder is actually dominant. Non-government organizations, side-by-side government organizations are running largest health programs. And the design of these all health programs are determined by a lot of factors, often by the availability of the funding, by the concentration of global disease burden, and also the areas even chosen by the funders. But still, the non-government organization and the government organization work side by side to provide healthcare. But when we are talking about this, basically the entire health services designed by Health, Population, Nutrition, Sector Development Program, which is also an international strategy advocated by International Monetary Fund or the World Bank. So, and they have different operation plans for different focus on different aspects of health. And according to my review, none of the operation plan basically talks about oral health. For the community level, if I look at, they have a very specific operational plan, which is community-based healthcare, and under which we have community clinics at the grassroots level. And none of the area, I mean, this operational plan talks about oral health care. So it's a very legal question that how the healthcare basically is provided in the community. So at the community level, we have frontline health workers, often on government payroll or often working with the non-government organizations. And Bangladesh has really made a good progress of exploiting internal community resources, how these people can be used as a frontline health workers. And some of the non-government organizations, and health workers who make household visit from one house to another and do interpersonal communications on health issues, and also they sell some of the health whenever they sell that basically some part of that goes to their income, but primarily they don't have any direct salary from the organization. Rather, they get to social capital, like they are interacting with different works and people, so they have a kind of social capital, which is kind of their, I would say, in their salary part in terms of other way of looking at. So when I say like these frontline health workers are the main person who provide health for anything, even including oral health. So by saying, I also want to emphasize like oral health care is basically neglected, as I was mentioning in my previous occasions. So what happens for a kid if they have an issue with their mouth? The rural pharmacy or the frontline health workers or other informal health, they are the first-hand response team who, has a very basic training or even don't have any training sometime. So whatever medicine, anyone's going to a pharmacy and says, I have pain in my mouth. So if they have a painkiller or some essential drugs they provide, and if that works, that's basically intervention. And if that doesn't work, or in a very serious case, they may make an effort to visit a specialized dentist or a specialized healthcare. So that's how I think the oral lies in the structure of Bangladesh, and this oral healthcare is maintained. I'm just kind of giving you a outline of Bangladesh context.
Thank you. I appreciate that. And I think it's helpful, and we don't always look outside of our own country. And I think it's really helpful to hear some perspectives about models that may be working somewhat effectively, and to consider some things that you've shared with us today when we think about where is healthcare going in our own country and who can be involved in that care in the community level. So thank you for that.
Thank you.
I appreciate it. I'd like to ask a quick question of the whole group, and you don't all have to answer, but if you'd like to answer, I'd ask you to raise your hand. And any other comments that you might want to make. I'm looking at the chat and I don't. I think I'm going to move along to the question I was going to ask first, and then if we have some time, we can jump into these. I think the question I have for the whole group is, in reflecting on your work with underserved communities, how did you meet the needs? How do you meet the needs of the entire person or family or community with specific consideration of holistic health of the mind, mouth, and body? I think, Kushik, you've answered that some with the CHWs that are in the community going door to door. Angel, I know you talked a lot about working with the parents. I wondered if there are things that you're doing in the schools. And Ashley, similarly, if you, or maybe Ashley, what you're doing in the schools, and thinking about how you deal with patients that are traumatized. during their dental care and how that gets passed along to their children. We've heard some answers to that. Are there strategies related to prevention or other work that goes on in the schools with the children themselves?
Yes, I'd like to chime in on that one. As part of our initiative that we do here at the Sac and Fox Nation is we try to press preventative and try to be proactive instead of reactive. One of our outreach programs has been our community health department goes to all the schools in our jurisdiction, and we provide dental education on how to brush, what it is like to go to the dentist. We provide them with toothbrushes, toothpaste, and floss. We come in our nursing attire with our scrubs so that they know that when you go to the dentist, it's not always scary. We had a child that was really scared to come into the room while we was trying to do a education demonstration, and we had to reassure him that he wasn't getting shots from us that day. And we showed him our mouth that we had brought. We showed him the toothbrush, and he got really interested and excited to come, and was really happy at the end when he got his goodie bag of his toothbrush and toothpaste. So that is something here in Indian country that we're trying to do, is be more proactive with the new generation.
Great, thank you.
Thanks for that question. I don't have a mic.
Yeah,
Anita, I do think there, oh, I'm sorry. I'm so sorry. Go ahead, Trina.
Oh, okay. I didn't know if you wanted me to speak. I would say based off of me going into the communities of churches as well, having fairs, workshops in our local churches and communities that I've done in the past after seeing some things that have happened with my sister, and then getting involved with more organizations. I know you asked about the schools, but I think that if we go into other nonprofit organizations such as churches and other facilities that may be able to offer those things, working in collaboration. I think that's what I've seen in the past with what I've done, working to educate people on regards of dental care. Thank you.
Thank you.
Anita, we do have a question in the Q&A section, which I'm happy to read out for the group. And that is everyone aware of the capabilities of the dental therapist program in Alaska and Minnesota that allows dental therapists to go to schools and communities to treat dental disease with the use of teledentistry? Dental therapists can extract primary teeth, treat caries, and perform restorations for children and adults. So in other words, I think taking oral health care to where patients reside or attend school. And I did not, as a school nurse by training, I did not pay this person to bring up schools. Anyway, would anybody like to answer that?
I could actually comment on that briefly, Miami. I was just recently stepped down as chair of the advisory committee at HRSA's Advisory Committee on Training in Medicine and Dentistry. And that committee actually just did a report. We issued a report last year of recommendations to the Secretary of HHS and Congress, recommending that dental therapy be funded through Title VII to expand and grow the profession, but to include not only funds for programs and faculty and student scholarship for loan repayment, but also long-term evaluation to really help us better understand the impact of that profession and how that may or may not meet our needs going forward. Others that have more personal experience with dental therapy or other thoughts about that, I think we'd love to hear about it. I don't see any hands. Do you see anything, Miami, at your end?
No,
Anyway.
we do have some questions in the chat. We do have one that's directed to Dr. Brown. And they said, I'm so sorry for your loss. Do you think your sister's dental care could have helped with teledentistry? We have dental providers who work with patients with special needs, and caregivers take photos on their cell phones so the dentist can do an exam. Sometimes, often, the patient meeting the dentist on video makes the in-person visits go more smoothly.
Thank you for the question. And I stated to the lady that I think it was Miss Colleen, Dr. Colleen, I don't know, I remember. But I know that back then they did not have, the facility was based on the facility. They wouldn't allow me to take pictures. I had the video, I have a lot of videos that I had to do, but that they wouldn't take a picture. But that will be something that I think prior to the pandemic and everything, it wasn't available, but now it's definitely a need. And I think that would be something that we should implement in all from the healthcare as well as the dentistry part of it, because it makes it easier for the doctor to see the patient from that level. So I think that is definitely something of virtual as well as pictures will make a big difference going forward.
I appreciate that comment. I think one of the things that we could tie teledentistry to, and I'm interested in the perspective of our community health workers also on this call, is how do you think the families that you work with will respond to teledentistry, and how might we help them prepare for a world where that's an option for them?
I think that teledentistry will be awesome, especially for working parents or guardians. It kind of can work around their schedules. And with COVID now, you know, a lot of things were telehealth and teledentistry. So I think going forward, it will be a great, you know, something great to do for, you know, people that are having restricted schedules. I think a teledentistry where they don't have to go into the dentist and actually see the chair, because sometimes the chair can bring on memories, but just to see a person face to face on a platform like this, or it brings peace. It can bring some sense of peace.
Right. Well, I think we're almost out of time. I want to thank the panel for your inspiring stories, for sharing your challenges as well as some of your successes, and also to help us think differently and have a window into the communities that you work with, and the humans, people that you work with, and how we can begin to address the idea of bringing the body together, because we know that as long as oral health and the mouth stays siloed from the rest of the body, we're still going to be struggling to try to get particularly the entire healthcare team to work together around oral health care as an essential component of whole person care. And as we talk a lot these days about the fact that without that integration and without that collaboration across the entire healthcare team, it's going to be very difficult to create a system of equitable oral health care. So thank you. We really appreciate your participation. And I would like to turn the mic back to you, Mayumi. Thank you.
Thank you, Anita, and also to all our panelists for, as Anita mentioned, giving us the gift of your stories and experiences, and just reminding us how important this work is in protecting and promoting the health of our families and communities. So thank you very much. I'd like to now introduce Richard Berman and Julian Fisher, who will co-moderate the next session that is really meant to bring all of our thinking today together as we think about and consider how we might operationalize a new model for designing demonstration projects targeting underserved communities. So by way of introduction, Richard is the Associate Vice President for Strategic Initiatives for Innovation and Research at the University of South Florida and an elected member of the National Academy of Medicine. Julian is a policy advisor and analyst specializing in health workforce education, social and environmental determinants of health, and global oral health. Their full bios are also in the agenda packet, and so I will refer you to the packet if you want to know more information. So Julian, Richard, I will turn it over to you to moderate our next session.